101. What is a classic ECG finding in hypocalcemia? A. Shortened QT interval. B. Prolonged QT interval. C. Tall T waves. D. No change in ECG. Answer. B. Prolonged QT interval. Rationale. Hypocalcemia typically leads to a prolonged QT interval because of delayed repolarization in the ventricles due to decreased calcium levels. 102. Which of the following ECG findings is most suggestive of pericarditis? A. PR segment depression. B. ST segment elevation in all leads. C. Widened QRS complex. D. Inverted T waves. Answer. B. ST segment elevation in all leads. Rationale. ST segment elevation in all leads is characteristic of pericarditis, often seen with a concave upward shape and no reciprocal ST depression. 103. What is the most significant ECG feature of atrial fibrillation? A. Absence of P waves. B. Prolonged PR interval. C. Wide QRS complex. D. Sawtooth P waves. Answer. A. Absence of P waves. Rationale. In atrial fibrillation, the P waves are absent due to the irregular, chaotic atrial electrical activity, leading to an irregular rhythm. 104. What is the likely cause of ventricular tachycardia on the ECG? A. Increased vagal tone. B. Atrial fibrillation. C. Myocardial infarction. D. Hypokalemia. Answer. C. Myocardial infarction. Rationale. Ventricular tachycardia is often caused by myocardial infarction, which leads to reentry circuits in the ventricles. This results in rapid and abnormal ventricular depolarization. 105. Which of the following ECG findings is most commonly associated with left ventricular hypertrophy, LVH? A. Tall R waves in V1 and V2. B. Deep S waves in V1 and V2. C. Prolonged PR interval. D. Low voltage QRS complexes. Answer. B. Deep S waves in V1 and V2. Rationale. Deep S waves in V1 and tall R waves in V5 or V6 are commonly seen in left ventricular hypertrophy due to increased muscle mass in the left ventricle, which causes changes in the electrical axis of the heart. 106. What ECG finding is characteristic of Wolff-Parkinson-White syndrome, WPW? A. Delta wave. B. T wave inversion. C. ST segment depression. D. Prolonged QT interval. Answer. A. Delta wave. Rationale. WPW syndrome is characterized by a delta wave, which results from the early activation of the ventricles due to an accessory pathway. This wave is seen as a slurred upstroke in the QRS complex. 107. In sinus tachycardia, what is the expected heart rate? A. 40 to 60 beats per minute. B. 60 to 100 beats per minute. C. 100 to 150 beats per minute. D. Greater than 150 beats per minute. Answer. C. 100 to 150 beats per minute. Rationale. Sinus tachycardia is defined by a heart rate of greater than 100 beats per minute, but less than 150 beats per minute, typically caused by increased sympathetic stimulation or other factors such as fever or anxiety. 108. What is a classic ECG finding in right atrial enlargement? A. Tall, peaked P waves. B. Flattened P waves. C. Biphasic P waves. D. Inverted P waves. Answer. A. Tall, peaked P waves. Rationale. Right atrial enlargement leads to tall, peaked P waves, especially seen in leads 2, 3, and AVF, due to increased pressure and muscle mass in the right atrium. 109. What does the presence of U waves on an ECG typically indicate? A. Hyperkalemia. B. Hypokalemia. C. Myocardial infarction. D. Atrial fibrillation. Answer. B. Hypokalemia. Rationale. U waves are most often associated with hypokalemia and represent delayed repolarization of the ventricles. They are typically seen after the T wave. 110. What is the most common cause of right bundle branch block, RBBB? A. Chronic obstructive pulmonary disease, COPD. B. Myocardial infarction. C. Aortic stenosis. D. Pulmonary embolism. Answer: A. Chronic obstructive pulmonary disease, COPD, rationale. RBBB is commonly seen in patients with chronic obstructive pulmonary disease, COPD, due to the increased pressure on the right side of the heart, which leads to delayed conduction in the right bundle. 111. What is the primary cause of second-degree type I AV block, Wenckebach? A. Increased vagal tone. B. Myocardial infarction. C. Electrolyte imbalances. D. Chronic hypertension. Answer: A. Increased vagal tone, rationale. Second-degree type I, Wenckebach. AV block is often caused by increased vagal tone, which slows conduction through the AV node and results in progressively longer PR intervals until a beat is dropped. 112. Which ECG finding is associated with hypothermia? A. Prolonged QT interval. B. Osborn waves, J waves. C. Widened QRS complex. D. Tall T waves. Answer: B. Osborn waves, J waves, rationale. Osborn waves, also known as J waves, are seen in hypothermia and reflect abnormal depolarization in the ventricles due to low body temperature. 113. What is the hallmark ECG finding of long QT syndrome? A. Shortened QT interval. B. Prolonged PR interval. C. Prolonged QT interval. D. Inverted P waves. Answer: C. Prolonged QT interval, rationale. Long QT syndrome is characterized by a prolonged QT interval, which predisposes to life-threatening arrhythmias such as torsades de pointes. 114. What does ST segment elevation in leads V1 to V4 indicate? A. Inferior myocardial infarction. B. Anterior myocardial infarction. C. Left bundle branch block. D. Right ventricular hypertrophy. Answer: B. Anterior myocardial infarction, rationale. ST segment elevation in leads V1 to V4 is indicative of an anterior myocardial infarction affecting the left ventricle's anterior wall. 115. Which of the following ECG findings is most consistent with atrial tachycardia? A. Regular, narrow QRS complexes. B. Irregular rhythm with absent P waves. C. Sawtooth pattern. D. Wide, bizarre QRS complexes. Answer: A. Regular, narrow QRS complexes, rationale. Atrial tachycardia typically presents as a regular rhythm with narrow QRS complexes and an abnormal P wave, often with a faster atrial rate. 116. What is the ECG characteristic of Brugada syndrome? A. ST segment elevation in V1, V3. B. Prolonged QT interval. C. Delta wave. D. T-wave inversion in leads I and AVL. Answer: A. ST segment elevation in V1, V3, rationale. Brugada syndrome is characterized by ST segment elevation in the right precordial leads, V1, V3, and can predispose to sudden cardiac arrest due to abnormal repolarization in the right ventricle. 117. Which of the following ECG findings is associated with atrial flutter? A. Irregularly irregular rhythm. B. Sawtooth pattern of P waves. C. No P waves. D. Prolonged QRS complexes. Answer: B. Sawtooth pattern of P waves, rationale. Atrial flutter is characterized by sawtooth-shaped P waves due to the rapid, repetitive atrial depolarization, typically around 250 to 350 bpm. 118. In third-degree heart block, which ECG feature is most prominent? A. P waves with irregular ventricular rhythm. B. Complete dissociation between atrial and ventricular rhythms. C. Prolonged PR interval. D. No P waves. Answer: B. Complete dissociation between atrial and ventricular rhythms, rationale. In third-degree heart block, there is complete dissociation between the atrial and ventricular rhythms due to the blockage of conduction at the AV node. 119. What does anterior wall myocardial infarction on an ECG typically show? A. ST segment elevation in leads V1, V4. B. ST segment elevation in leads 2, 3, AVF. C. Deep T-wave inversion in V5 and V6. D. ST segment elevation in leads V5, V6. Answer: A. ST segment elevation in leads V1, V4 rationale. Anterior wall myocardial infarction typically shows ST segment elevation in the anterior leads V1, V4, corresponding to the left anterior descending arteries supply. 120. What is the primary ECG finding in pulmonary embolism? A. T-wave inversion in leads 2, 3, AVF. B. Sinus tachycardia. C. Prolonged QT interval. D. Deep S wave in lead V1. Answer. B. Sinus tachycardia rationale. Pulmonary embolism commonly causes sinus tachycardia as a result of hypoxia and increased sympathetic stimulation. Other findings may include right heart strain, but sinus tachycardia is often the first clue. 121. Which ECG finding is characteristic of hyperkalemia? A. Prolonged QT interval. B. Tall, peak T waves. C. U waves. D. Shortened PR interval. Answer. B. Tall, peaked T waves rationale. Hyperkalemia is characterized by tall, peaked T waves due to delayed repolarization. Severe hyperkalemia can lead to a widened QRS complex and even a sine wave pattern. 122. What is the presence of Q waves in the inferior leads 2, 3, AVF suggest? A. Anterior myocardial infarction. B. Right ventricular hypertrophy. C. Inferior myocardial infarction. D. Left bundle branch block. Answer. C. Inferior myocardial infarction rationale. Q waves in the inferior leads are typically indicative of an inferior myocardial infarction, which involves the lower part of the left ventricle. 123. What is the most common ECG finding in pulmonary embolism? A. Sinus bradycardia. B. Right axis deviation. C. Sinus tachycardia. D. Prolonged QT interval. Answer. C. Sinus tachycardia rationale. Sinus tachycardia is the most common finding in pulmonary embolism, often as a result of hypoxia and increased sympathetic tone. 124. What is the ECG hallmark of hypothermia? A. Prolonged PR interval. B. Osborne J waves. C. Tall T waves. D. Shortened QT interval. Answer. B. Osborne J waves rationale. Osborne waves, also known as J waves, are seen in hypothermia due to delayed depolarization of the ventricular myocardium, often observed in the precordial leads. 125. In left bundle branch block, LBBB, what is the typical appearance of the QRS complex? A. Narrow QRS complex. B. Wide QRS complex with a notched R wave. C. Wide QRS complex with deep S waves. D. Prolonged PR interval. Answer. B. Wide QRS complex with a notched R wave rationale. LBBB is characterized by a wide QRS complex greater than 120 milliseconds with a notched or slurred R wave in leads I, AVL, V5, and V6 as the left ventricle depolarizes later than the right ventricle. 126. What does a bifascicular block on the ECG involve? A. Left anterior fascicle and left posterior fascicle. B. Left bundle branch and right bundle branch. C. Right bundle branch and left anterior fascicle. D. Right atrial enlargement and left ventricular hypertrophy. Answer. C. Right bundle branch and left anterior fascicle rationale. A bifascicular block involves a combination of right bundle branch block, RBBB, and left anterior fascicular block, leading to a characteristic pattern of conduction delay in the ECG. 127. What does ST segment depression in leads 2, 3, and AVF indicate? A. Inferior myocardial infarction. B. Ischemia or subendocardial infarction. C. Left ventricular hypertrophy. D. Pericarditis. Answer. B. Ischemia or subendocardial infarction rationale. ST segment depression in the inferior leads is typically a sign of ischemia, often indicative of subendocardial infarction or ongoing ischemia in the inferior wall of the heart. 128. Which of the following ECG features is most suggestive of ventricular fibrillation? A. Wide, bizarre QRS complexes. B. Rapid, erratic, and disorganized electrical activity. C. Regularly irregular rhythm. D. P waves with absent QRS complexes. Answer: B. Rapid, erratic, and disorganized electrical activity. Rationale: ventricular fibrillation is characterized by rapid, erratic, and disorganized electrical activity with no identifiable P waves, QRS complexes, or T waves. 129. What is the most likely ECG finding in hypercalcemia? A. Shortened QT interval. B. Prolonged QT interval. C. Flattened T waves. D. Peaked P waves. Answer: A. Shortened QT interval. Rationale: hypercalcemia is typically associated with a shortened QT interval as calcium affects myocardial contractility and repolarization. 130. What does the presence of delta waves indicate in the ECG? A. Left bundle branch block. B. Wolff-Parkinson-White syndrome. C. Acute myocardial infarction. D. Atrial fibrillation. Answer: B. Wolff-Parkinson-White syndrome. Rationale: delta waves are characteristic of Wolff-Parkinson-White syndrome, where an accessory pathway causes early ventricular depolarization, manifesting as a slurred upstroke in the QRS complex. 131. What does ST segment elevation in lead V1 usually suggest? A. Inferior myocardial infarction. B. Anterior myocardial infarction. C. Right ventricular infarction. D. Left bundle branch block. Answer: C. Right ventricular infarction. Rationale: ST segment elevation in lead V1 is often associated with right ventricular infarction, which can occur with inferior myocardial infarction involving the right coronary artery. 132. Which ECG feature is most characteristic of torsades de pointes? A. Prolonged PR interval. B. Polymorphic ventricular tachycardia. C. Wide, irregular QRS complexes. D. Sawtooth P waves. Answer: B. Polymorphic ventricular tachycardia. Rationale: torsades de pointes is a form of polymorphic ventricular tachycardia with a characteristic twisting of the QRS complexes around the baseline, often associated with a prolonged QT interval. 133. What is the main feature of second-degree type 2 AV block, Mobitz type 2? A. Progressive PR interval prolongation. B. Dropped beats with no change in the PR interval. C. Complete dissociation between atria and ventricles. D. Prolonged QT interval. Answer: B. Dropped beats with no change in the PR interval. Rationale: in Mobitz type 2, there is a sudden drop in a QRS complex without progressive PR interval prolongation, and the PR interval remains constant before the dropped beat. 134. What does ST segment elevation in leads V5 and V6 most likely indicate? A. Inferior myocardial infarction. B. Lateral myocardial infarction. C. Anterior myocardial infarction. D. Left atrial enlargement. Answer: B. Lateral myocardial infarction. Rationale: ST segment elevation in leads V5 and V6 is characteristic of lateral myocardial infarction involving the left circumflex coronary artery. 135. What is the classic ECG finding in left atrial enlargement? A. Broad, notched P waves in lead 2. B. Peaked T waves. C. Shortened PR interval. D. Prolonged QRS complex. Answer: A. Broad, notched P waves in lead 2. Rationale: left atrial enlargement is often seen as broad, notched P waves in lead 2, reflecting increased pressure and volume in the left atrium. 136. In Wolff-Parkinson-White syndrome, what is the primary cause of the abnormal ECG findings? A. Blockage in the AV node. B. An accessory pathway between the atria and ventricles. C. Congenital long QT syndrome. D. Myocardial infarction. Answer: B. An accessory pathway between the atria and ventricles. Rationale: Wolff-Parkinson-White syndrome is caused by an accessory pathway that bypasses the normal AV node conduction, leading to early ventricular depolarization, which manifests as the delta wave on ECG. 137. What is the most likely diagnosis when the ECG shows a sinus rhythm with absent P waves and wide QRS complexes? A. Atrial fibrillation. B. Ventricular tachycardia. C. sinus tachycardia. D. Supraventricular tachycardia. Answer: B. Ventricular tachycardia. Rationale. Ventricular tachycardia is characterized by wide QRS complexes and absent P waves due to abnormal electrical activity originating in the ventricles. 138. What is a common ECG finding in hypokalemia? A. Tall, peak T waves. B. Flattened T waves. C. Shortened QT interval. D. Prolonged PR interval. Answer: B. Flattened T waves. Rationale. Hypokalemia typically leads to flattened T waves and may also cause U waves and other repolarization abnormalities. 139. What does ST segment depression in leads I, AVL, and V5 most likely suggest? A. Left anterior descending artery ischemia. B. Left circumflex artery ischemia. C. Right coronary artery ischemia. D. Anterior myocardial infarction. Answer: B. Left circumflex artery ischemia. Rationale. ST segment depression in leads I, AVL, and V5 is commonly associated with ischemia involving the left circumflex artery, which supplies the lateral wall of the left ventricle. 140. What is the ECG finding associated with hyperthyroidism? A. Sinus bradycardia. B. Sinus tachycardia. C. Atrial fibrillation. D. Prolonged PR interval. Answer: B. Sinus tachycardia. Rationale. Hyperthyroidism often causes sinus tachycardia due to increased sympathetic stimulation as well as an increased metabolic rate. 141. What does a prolonged PR interval greater than 300 milliseconds suggest? A. First-degree AV block. B. Second-degree AV block. C. Third-degree AV block. D. Wolff-Parkinson-White syndrome. Answer: A. First-degree AV block. Rationale. A prolonged PR interval greater than 300 milliseconds is characteristic of first-degree AV block, where the electrical impulse is delayed but still reaches the ventricles. 142. What ECG finding is commonly seen in hypothermia? A. Shortened QT interval. B. Osborne J waves. C. Tall T waves. D. ST segment elevation. Answer: B. Osborne J waves. Rationale. Osborne waves, J waves, are classic signs of hypothermia, reflecting delayed repolarization in the ventricles. These are seen in the precordial leads. 143. What does a positive T wave inversion in the precordial leads typically indicate? A. Acute myocardial infarction. B. Normal variant. C. Pericarditis. D. Pulmonary embolism. Answer: A. Acute myocardial infarction. Rationale. T-wave inversion in the precordial leads is often seen in the setting of acute myocardial infarction, particularly in the early stages, as a sign of ischemia. 144. What ECG finding is most associated with digitalis toxicity? A. T-wave flattening. B. ST segment depression. C. Shortened QT interval. D. Downsloping ST segment with salvage effect. Answer: D. Downsloping ST segment with salvage effect. Rationale. Digitalis toxicity is associated with characteristic ST segment depression with a salvage effect, where the ST segment is often sloped downward with a scooped appearance. 145. What ECG finding suggests acute pericarditis? A. PR segment depression in leads 1, 2, AVL. B. Flattened T waves. C. ST segment elevation in multiple leads. D. Left axis deviation. Answer: C. ST segment elevation in multiple leads. Rationale. In acute pericarditis, widespread ST segment elevation, concave up, in multiple leads, particularly in the precordial leads, is a characteristic finding. 146. What does the absence of P waves with a regularly irregular rhythm usually indicate? A. Atrial fibrillation. B. Atrial flutter. C. Junctional rhythm. D. Ventricular tachycardia. Answer: B. Atrial flutter. Rationale. In atrial flutter, the rhythm is regularly irregular with a characteristic sawtooth pattern of flutter waves instead of P waves. 147. What does a prolonged QT interval predispose a patient to? A. Premature atrial contractions. B. Torsades de pointes. C. Ventricular fibrillation. D. Right bundle branch block. Answer: B. Torsades de pointes. Rationale: a prolonged QT interval is a risk factor for torsades de pointes, a type of polymorphic ventricular tachycardia that can lead to sudden cardiac arrest. 148. In right bundle branch block, RBBB, what is the typical appearance of the QRS complex? A. Narrow QRS complex. B. Prolonged PR interval. C. Wide QRS complex with an RSR pattern. D. Wide QRS complex with a notched R wave. Answer: C. Wide QRS complex with an RSR pattern. Rationale: right bundle branch block is characterized by a wide QRS complex greater than 120 milliseconds with an RSR pattern in leads V1 and V2, indicative of delayed right ventricular depolarization. 149. What does a prolonged QT interval on an ECG increase the risk of? A. Sinus bradycardia. B. Atrial fibrillation. C. Sudden cardiac death. D. Heart block. Answer: C. Sudden cardiac death. Rationale: a prolonged QT interval increases the risk of life-threatening arrhythmias, including torsades de pointes and sudden cardiac death. 150. What does a U wave on the ECG indicate? A. Hyperkalemia. B. Hypokalemia. C. Left ventricular hypertrophy. D. Atrial fibrillation. Answer: B. Hypokalemia. Rationale: U waves are often associated with hypokalemia and are seen as a deflection after the T wave. These waves can also be seen in other conditions like bradycardia and heart disease.